Good evening. I'm Ira Katznelson, Interim Provost at Columbia, and I want to offer a warm welcome to this campus forum on COVID-19 vaccines. Our purpose is to gain information and to discuss questions of distribution. And we're privileged to have a terrific panel. Our panelists include Donna, Lynne, the Senior Vice President and Chief Operating Officer at CUIMC and University COVID Director, Wafaa El-Sadr, University Professor of Epidemiology and Medicine and Director of ICAP at Columbia, Magda Sobieszczyk, Chief of Infectious Diseases and Co-Chair of the CUIMC COVID-19 Vaccine Committee, and Gerry Rosberg, Senior Executive Vice President, who's been directing our vaccine efforts. And now I'm very pleased to turn over to Donna.
Well, good afternoon, everyone, and thanks for joining us. There is a Q&A function on your Zoom that you can use to ask questions. During the presentation, some of us will try to answer them online, but we'll leave plenty of time in today's presentation to actually get to questions live. I want to just start by explaining a little bit about the program, who is eligible, and what some of the conditions are. So first of all, the eligibility group is important to understand. The Centers for Disease Control that's part of the federal government created some guidelines around what eligible groups should look like in terms of priorities. As I think you're well aware, the demand for the vaccine greatly exceeds the supply. And so decisions around who should go first are recommended by the CDC, but every state makes their own decisions. And so here in New York State, as we rolled out the vaccine, the availability of which started on December 15th, the governor said the first group that should get this actually are patient-facing faculty and staff who work in hospitals, nursing homes, or other healthcare facilities. That was expanded a little bit to include some support staff for patient-facing individuals. So not unusual to have somebody like a custodial facilities employee who is in a hospital, for example, to be eligible. It was expanded to what is now called 1B. Again, these are the first categories, which includes any patients age 65 and over, public safety workers, public transit workers, and education workers, including the workers in universities who are doing in-person instruction only. The governor also announced that there ought to be a consideration for people who are immunocompromised, but has not issued what immunocompromised means yet, so we are not vaccinating them. The number of people in these two categories is very large. It's over 7 million in New York State, but our supply right now is only 300,000 per week. One thing that we really want to make clear is that Columbia does not have the vaccine. We are working with New York Presbyterian Hospital, who is our partner on the medical center, to provide access to our own Columbia employees and students who are patient-facing, and ultimately, as we've rolled out phase 1B, to individuals who are age 65 and over who have been patients or would be considered a patient. We're not through this group. We've done just at the NYP and Columbia sites, we've done about 38,000 first doses, but there are many more people who are in this category of first doses. For many of you who are not over the age of 65 or not doing in-person instruction or who don't fit into those other categories, the estimates are it will be until another 5 months or so before we can get to you. You can go to the next slide. Just numerically, high level, you've probably heard, out of 330 million people in the United States, some of whom are children and who we do not vaccinate, As of 2 days ago, just about 11 million people had gotten their first doses nationally. Here in New York City, it's around almost 400,000 now. And the mayor's goal, as you may have heard, is to get to 1 million. But the uptake in terms of vaccine administration has really accelerated in the last couple of weeks. Next slide, please. As I mentioned, I have to say it over and over again, Columbia doesn't have the vaccine. However, Columbia doctors and Columbia Health have both applied to be vaccine providers when the distribution moves away from hospitals and from city-run sites. We are using currently both the Pfizer and Moderna vaccines. And the access point for many of you who are listening as of this past Thursday is the Armory on 168th Street in Fort Washington. We've done 10,000 doses of the public since last Thursday. And many folks, and Gerry will talk a little bit about this, are eligible to volunteer at the Armory. And also, despite those categories that I enumerated, once you work in the Armory, you are in fact patient-facing and will be able to get the vaccine. We have continued, though, to emphasize that whether you have the vaccine or not, that all of the safety measures that we have at Columbia, including face covering, physical distancing, our gateway testing programs, all still apply whether you have or have not had the vaccine. And then we are vaccinating a lot of people, and you'll hear from Wafaa and Magda about the fact, though, that even amongst those eligible groups, not everyone is taking the vaccine. And we want to work with all of you to answer your questions that might make you somewhat hesitant or worried, because this is, as many of us often say, a race against the COVID positivity rates that we are seeing increasing, not just in New York, but around the country. And you can go to the next slide. So 2 things to remember in terms of once you leave this town hall, there are 2 important websites. One is vaccinetogetherny.org. That's where you can sign up to get the vaccine at the Armory. And the other is covid19.columbia.edu, which is our university website. And I would just add too that to the extent it's hard to get appointments, persevere, go online and try to get them. But you also have accessible to you city locations that you can get through the Department of Health website. So with that, I'm going to turn it over to Wafaa, who's going to talk a little bit about the vaccine itself and some of the science behind the development, as well as other questions that fall into that area. Wafaa?
Great, and thank you. And thank you very much. I think, yes, stop sharing, and then I'll share my screen. Okay. So let me get started first by welcoming all of you today, and I'll be very quick and give you a vaccine update that may answer some of the questions you have in mind. So I think one of the important questions that everybody asked us is, how well do these vaccines work? And that's really a critical question. The 2 vaccines that are available now in the United States for vaccinating individuals are the Pfizer-BioNTech vaccine and the Moderna vaccine. And both of these vaccines are remarkably effective at the prevention of symptomatic COVID-19. And this is important to keep in mind, meaning that what we know from large studies that were conducted recently is they are very, very efficacious, very, very good at preventing development of disease, of COVID-19 disease. We don't know for sure whether they will be effective or not in preventing infection. And that's why it's really critically important, infection meaning asymptomatic infection. And that's why it's critically important to continue to wear masks and distance and so on, even after getting vaccinated. I want to tell you, of course, that both of these vaccines have required 2 doses. For the Pfizer-BioNTech vaccine, day 1 and day 21, while for the Moderna vaccine, day 1 and day 28. And it's important that as much as possible to stick to the recommended regimen because these are regimens that were studied in the large studies that provided the data on these vaccines. Importantly, and I'll get into it a little bit later, is in terms of safety, both of these vaccines have a very comforting and safety profiles. No serious side effects have been noted, and most of the side effects have been mild to moderate, and most of them have been local at the site of injection. So another question is, who are the people who participated in the vaccine studies? People always ask, who are these participants, and do they reflect the breadth of the people who should get the vaccine? Importantly, half were women. Also in terms of racial ethnic diversity, as you can see here, about 9% were African Americans versus, again, in both of these studies, 28% were Latinx population versus 20% in the Moderna vaccine studies. Another question that's asked is, did these studies include older individuals? And you will note that in the Pfizer vaccine study, fully 42% were 55 years or older, and in the Moderna study, 25% were 65 years or older. So that's really critically important. And then comorbidities, meaning other medical conditions. Did the participants have substantial number of participants have these conditions? You can see here in the Pfizer study that fully half of the participants did have comorbid conditions, and Magda will get into some of these conditions. And similarly as well, at least having at least one of these comorbid conditions, 22 of the participants in the Moderna vaccine had some of these conditions. Now, another question that gets asked all the time is, did these vaccines in these studies work for all the groups that I mentioned to you just now? And I think there have been some interesting analyses that show that here, for example, this is from the Moderna study, is that when you look by overall, as I mentioned, very high efficacy, more than 90%. And then you can look at different age groups, again, very, very comforting high efficacy. If you look by sex, again, consistently high efficacy. And if you look at people with and without comorbidities, again, we see that these vaccines work very well for people with and without these comorbidities. And lastly, very importantly, when we look at the data by race, ethnicity, again, we're seeing consistently high levels of efficacy for these vaccines. Now, what about side effects? And I'm using the example of the Pfizer-BioNTech vaccine here. And as I mentioned, most of the side effects are mild to moderate. Most are local, meaning at the site of injection, pain, redness, a bit of swelling. And what's interesting is you can see from these data here, which I don't have time to go through, but you will have these in the recording of the webinar, that younger individuals actually are more likely to have these reactions, these local reactions, meaning they're a little bit more likely to have these local pain, redness, or swelling versus older individuals greater than 55 years of age. Systemic side effects are less common, and Magda will get into some more details, most commonly headache and fatigue. And some people with some of the vaccines tend to have more reactions after the second dose. This has been particularly noted in young people after the Moderna vaccine. But again, all of these side effects have been mild to moderate, but they seem to be more prominent in some people after the second dose. What about the question of severe allergic reactions? We hear about this all the time, concerns about anaphylaxis or severe allergic reactions. So these are some data from the vaccine monitoring system that exists here in the US. And the data were examined for just 1 week of vaccination during December, where more than 1.8 million individuals received first doses of this vaccine. And amongst these individuals, 21 cases of anaphylaxis, meaning severe allergic reactions, were reported. And that's about 11 cases per million doses. So that's a rare event. The interesting thing is 71% of these occurred within 15 minutes of vaccination. So these happen promptly after, if they're going to happen, they're rare, but if they happen, they happen within 15 minutes of, the majority within 15 minutes of vaccination. And that's why we do recommend that everybody should be watched for 15 minutes after getting the injection. And for people who have had a history of severe allergic reactions in the past, they should be monitored for 30 minutes after receiving the vaccination. 80% of the people who had such reactions had a history of other severe allergic reactions, and about a third of those who had this episode had experienced an episode in the past of anaphylaxis after receiving other vaccines, for example, the rabies vaccine or influenza vaccine. This figure here shows that here's the date. This is 30 minutes after vaccination, that most of these few anaphylactic events occurred within 30 minutes after receiving the injection. There are two systems to monitor for safety after vaccination. One is an active surveillance system, and I strongly recommend that everybody who gets vaccinated, please download this app from the CDC. It's called vSafe, and this is active surveillance. So if you download the app and indicate that you've been vaccinated, you'll receive every day a message that asks you to indicate if you've had any side effects and what type of side effects, and if any of the side effects have interfered with you going to work and so on. So that's really a valuable system, and all of us should participate in it. In addition, there's also a passive surveillance system, and this is really a system whereby anybody, whether it be a healthcare provider, a manufacturer, or anyone from the public, can report any side effects from vaccines. Now, Donna did mention who should be prioritized, and I think in general, we prioritize people that fit into one or two categories. Either they are people who are at high risk for getting infected with the coronavirus and coming down with COVID-19, or they're at high risk of complications of COVID-19. So some of the people at high risk for infection, as you know, and that's why these are in the priority groups, are healthcare workers, essential workers, some of them listed here, some racial ethnic groups, for example, as well as people who reside or work in congregate settings. Now, what about people who have high risk of complications of COVID-19? This again includes older age individuals, people with comorbid conditions, and that's why they are recommended to get vaccinated once they become eligible, as well as pregnant women, because they are at higher risk of getting complications. In addition, we also know that certain racial ethnic groups tend to have more of these comorbidities and therefore are at higher risk, not just for infection, but also for complications from COVID-19. Now, why is it so important to get vaccinated? I think it's important to get vaccinated because it doesn't help to have a vaccine, a fantastic vaccine like these two very highly efficacious and safe vaccines sitting in the freezer or sitting on a shelf. In order for us to achieve the impact of vaccines, meaning the ability for us to protect the population, individuals and the population, we need to achieve two things. One is to be using a vaccine that has high efficacy, and we're very fortunate to have two vaccines now that are truly fantastic in terms of efficacy. But the other prerequisite is we need to achieve coverage. High coverage uptake of the vaccine is very important. And that's why it's really critical for individuals who are eligible to receive the vaccine based on the eligibility criteria that Donna shared with you, that we want to encourage such individuals, if they have questions, if they have concerns, to raise them so that they can get vaccinated and are protected from COVID-19, as well as for us to also achieve the high coverage we need. And it is by having this high uptake and high efficacy vaccines that we can achieve the desired positive impacts of a vaccination. Now, is it necessary to get two doses? Another question in terms of uptake. It really is critically important to get the two doses. This is for a couple of reasons. One is that we have data from studies that show that protective antibodies that developed from the injections of the vaccine after one dose don't appear to be any better than in the group that did not get vaccine, the placebo group. And that the antibody response, this protective response, immune response, is boosted strongly after the second dose of the vaccine. It's also important to note that in the studies that were done, the vast majority of people who participate in the studies got the 2 doses. So the evidence in terms of the efficacy of the vaccines that I mentioned to you before is based on people getting 2 doses, not 1 dose only. Now, in terms of achieving, so people have to get the vaccine and have to get high uptake as well as efficacious vaccines. How do we get to that? I think we recognize there's a continuum of vaccine acceptance. And this figure here shows what I mean. There are people who are on the right end of the spectrum, have the high demand, they really are ready for action, they're ready to make an appointment and get vaccinated, they're eager to get vaccinated. And the other end of the spectrum, there are people who are not believers, for example, in vaccines, have a lot of doubts about the vaccines in general, and maybe some doubts about these vaccines in particular. And then there are a lot of people in between that have may be thinking that maybe I'll wait and see, maybe I'll wait a little bit before I get vaccinated. So they fall into this passive acceptance phase group of individuals. And these are data from the United States that show that when you look at people when asked the question, is that if you're offered the vaccine, you're eligible, you're offered the vaccine, are you willing to definitely get it, probably not get it? People indicate, 40% indicated that they will definitely get it, 30% indicate they probably would get it, but then 12% they said probably not get it, and then 15% they indicated definitely not get it. So we're very concerned about people who fall here and want to address their concerns through a variety of means, providing more information, making obtaining vaccinations easy and available, going to where they're at rather than expecting them to come to us, as well as trying to demystify and try to address some of the myths that exist about vaccines overall and some of the misconceptions about these vaccines specifically. So one of the questions, and this is my last slide, is the concerns about how were vaccines developed so quickly. Several people keep asking this question. And I think, honestly, I think that the right question we should ask often, and certainly after the experience with these vaccinations, COVID-19 vaccines, is really the opposite, is why does it take so long to get vaccines developed? And we know now that it can be done fast, and that's really important. And it really is unacceptable to realize how long it's taken to get some vaccines out there, sometimes 10 to 12 years or so. So why did it happen quickly for the COVID-19 vaccines? Firstly, the vaccine developed, there was a head start. There have been years and years and decades of research on this methodology that was used, the approach, the technology that was used to develop these 2 vaccines. This was developed in efforts to develop vaccines for the first SARS outbreak from several years ago, as well as for another coronavirus that occurred in the Middle East, the Middle East respiratory virus, which was transmitted from camels to people. So already the research has been done, and the platform was there, and that enabled us to move quickly. I can assure you there were no shortcuts taken in the research process itself in terms of the different phases of the studies, as well as importantly is that while we often traditionally will go phase by phase by phase, and then once we have a hint of an effective vaccine, then we start manufacturing it. Here with the COVID-19 vaccine process, this was done rather than sequentially, it was done in parallel. And that enabled shortcutting some of the delays. And then another fact is that because of the enormous interest in COVID-19 vaccines in general, this motivated rapid enrollment in the studies. I know several people who participated in these studies, and they did it out of altruism and also knowing that they are contributing to trying to get an answer fast. And this is in contradistinction to some of the research sometimes that where people take months, if not years, to be able to successfully enroll participants. And then, of course, having an existing mechanism, which is called emergency use authorization at the FDA, that was utilized to be able to look at the data that was analyzed by independent investigators, independent experts, and then to move it to authorization by the FDA. And lastly, and importantly, I think when people ask me, what should I do differently the day after I get vaccinated? And the answer is nothing differently. We continue to do what we've been doing all along, continue to do that after we get vaccinated. Nothing really changes because we know that protection from vaccine is not immediate, that no vaccine is 100% effective, the duration of protection is not known, and also we don't know as of yet whether these vaccines will prevent infection, as I mentioned, and therefore we need to protect other people just in case we do get infected. Somebody who's vaccinated gets infected and unknowingly transmits it to someone else. So I guess the message is, important message is to continue to do what we're doing in terms of the measures, the protective measures that we've talked about again and again. Thank you very much. And I'll hand it over to Magda for her presentation now.
Great. Thank you, Wafaa, and thank you, everybody, for the opportunity to present to you some more COVID-19 vaccine updates. So what I wanted to focus right now is just sort of to talk about some of the lessons that we learned from implementation of these vaccines in the Columbia community, and do so through the lens of kind of most frequently asked questions that have come up related to the safety and efficacy of these vaccines in our communities. So as Wafaa mentioned, one of the most common questions is really about how generalizable are these vaccines to communities around us and to us. And specifically, are there individuals with certain comorbid conditions that were included in these studies? And what do we know about the safety and efficacy of these vaccines? So let's take a look at some of these questions. So one that comes up quite frequently is, I have asthma and type 1 diabetes. Is the vaccine safe and will it work in someone like me? And the answer to that is yes. We know that the vaccines appears to be safe and effective, and there are no contraindications to vaccinating individuals with diabetes and asthma. And we really know it from data from these Moderna and Pfizer-BioNTech studies, where a proportion of individuals, up to 22%, had medical conditions such as diabetes, heart disease, chronic lung disease, liver disease, and approximately 5 to 8% of them, several thousand, had underlying lung disease, including asthma. I should acknowledge that there are some limited data on individuals who have immunocompromising conditions or take medications that suppress their immune system. These individuals may potentially mount a more sort of less robust antibody response. However, because they are at increased risk of more severe COVID disease, it really is, they're encouraged to get vaccinated if there are no other contraindications to receiving the vaccine. And what about vaccine efficacy and safety in persons who've had prior COVID infection? So that's the other kind of key concept that I wanted to highlight. What do we know about these individuals? So what do the data from clinical trials tell us? Even though the individuals with prior COVID infections were not formally included in these studies, there was a small but significant number of individuals who had prior COVID infection, unknown perhaps to them, and who tested positive with antibodies or PCR at baseline testing at enrollment in these studies. So they really give us, the data from these individuals give us confidence to answer a few questions, such as, I had COVID back in May or last summer. Should I take the vaccine? And the answer to that would be yes, because of the inclusion of these individuals with prior SARS-CoV-2 illness and COVID-19 disease. And then we know that there were really no differences in vaccine safety and efficacy based on prior infection. And another question would be, I already had COVID in May. Do I actually need the vaccine? And the answer to that again is yes, that the vaccine should be offered regardless of history of prior infection, because we don't know how long natural immunity following natural infection lasts, and it varies from person to person. So the vaccine sort of offers you that kind of boosted immunity and responses, as Wafaa described. Another common question is, I'm scheduled to get my second dose in a couple of weeks, but my COVID test just came back positive. Can I still receive the second dose? And we now recommend that, yes, proceed with the second dose as long as you're out of isolation and out of quarantine, it's completed. And the second dose should be given as close as possible to the original date of the scheduled visit. So as in closing, I just wanted to reflect a little bit more on some of the lessons learned from implementation here at the Columbia campuses, and what some of the reported side effects have been among the vaccinated individuals. So some of the more common reported reactions have been soreness at the injection site. As Wafaa mentioned, that was also seen in clinical trials. The next most common reported side effect were fatigue, headache, muscle aches and joint aches. Fever was less common. We have seen some more reactions after the second dose, but they usually sort of dissipate after a day or so, and especially can be relieved with Tylenol and Motrin that can be taken if these symptoms develop following vaccination. As with any medicine, allergies can be seen, but really this has been a rare event with this particular vaccine. And Wafaa shares some of the data for you about what's been seen nationwide, and this is similar also on our campus. So with that, let me close, and thanks again for the opportunity to share some of this with you.
So my role is to say a word about the volunteer program that exists in support of our partner, New York Presbyterian Hospital. This program is brand new. It's extremely exciting and I think a great opportunity for us. But because it's just literally days old, there are a lot of questions about it that are still work in progress. So if you have tried to register, if you've tried to volunteer and it doesn't seem to be working perfectly, be patient with us, please, because we're working hard to get the kinks out. Donna began this presentation by making a point that just needs to be stressed. Columbia University does not have any doses of the vaccine yet. We hope we will have them, but we don't have them now. All of the people at Columbia who have been vaccinated so far have been vaccinated thanks to the doses that are available to our partner, New York Presbyterian Hospital. I mention that because the hospital has now asked for our help. And I think it's really in our interest and the interest of our community that we provide the help if they can. They are looking for people to support this really unprecedented mass vaccination effort that they've undertaken. They are looking, most importantly of all, for people with clinical experience who can do the vaccination itself. If you have that kind of capability, great. They need you. They want you very badly to volunteer to help. But they're also looking for non-clinical people to play roles in registering patients, in navigating, in helping patients work their way through the system. They are asking for a minimum commitment. It's not something you do over your lunch hour. They need you to be there for an 8-hour shift, which, as you can see on the slide, is 6 to 2 or 2 to 10. And they want you to commit to doing 4 of those because this involves training and it requires an investment of time and effort to do it. This requirement that appears on the slide about the 4 8-hour shifts is for the non-clinical people. Even in the last 24 hours, we've come to understand that if you are a clinical person who can do vaccination, you should ask about the possibility of doing a shorter shift because that may be possible. That's how great is their eagerness to get them there. This is at the Armory. It's for employees only. We've had many people ask, could a spouse, a partner, a child do it? Sadly, no. It's only for our employees. The logistics are just too complicated if we're not already dealing with someone enrolled in our systems. The last point to make about this program is that if you volunteer, you will be considered a person in phase 1A, which means that you will yourself be eligible for vaccination. Exactly when the vaccination is going to be delivered, whether at the beginning or whether at the end, someplace in between, that's one of the things we're still working out. But the undertaking here is that you will be vaccinated. Many have asked whether they need to be vaccinated before they go in, that it wouldn't be safe, the thought is, to volunteer until you've been vaccinated. That's not how this works. You need to understand, if you're interested in volunteering, that thousands of our own people have been working, seeing patients, relying on personal protective equipment to keep them safe long before there was any vaccination. So that's the plan for people going in. It's not pre-vaccination, it's vaccination as part of this program. But let me pause there and let Donna proceed with the Q&A, which is always for me the most interesting part of this conversation.
Well, thank you, Gerry, and thanks to all of the panelists. I'm going to toss some questions. They are seeming to fall into several buckets. One is certainly about the vaccine itself and the efficacy and some of the other considerations. And then there are some eligibility questions that I'll be tossing to Gerry. So one question that I know both Magda and Wafaa mentioned the importance of people who have had COVID to get the vaccine, but there are a number of people who have written in who said, but I still have either long-term COVID or that I still have many of the symptoms of COVID. And so the question is, are those people also encouraged to get the vaccine?
I can start and then Magda can add. I think in reality, it really depends on the severity of the lingering symptoms. And we know, unfortunately, that some people do have lingering symptoms sometimes after COVID. I mean, if the symptoms are really disabling, it would be probably a good idea to wait until you feel a bit better. At the same time, keep in mind that most of the side effects, like I mentioned, for these vaccines are local rather than meaning at the site of the injection rather than systemic. So it's a matter of kind of weighing how one feels and so on. We do know, like I said, that vaccines do produce much better immune response than having had a COVID episode. So ideally, we'd like people, even people who've had COVID in the past, to get vaccinated. But I again recommend just a discussion with your provider to determine when is the best time. I don't know if you have something to add, Magda.
No, I agree with you, Wafaa, and it still is sort of, you know, this issue of kind of long COVID and prolonged symptoms is still an area of, you know, a lot of research, kind of as we gain understanding on exactly sort of what drives it. I agree with you completely in terms of the recommendations.
Great, well, thank you. A couple of other questions. How effective is the vaccine against the newer variants of COVID-2 that are emerging? Are the mutations something that is a cause for concern?
Want to start, Magda?
Sure, yeah. So this is, you know, I think as we're kind of gathering more understanding, gaining more understanding around sort of the transmissibility of the virus, the same follows in terms of, you know, how effective are either monoclonal antibodies against it or vaccines. So we don't have sort of the full picture yet, but there are a lot of laboratories that are working on trying to understand what the impact of the novel strains is on kind of the ability of the kind of the antibodies that are produced by the vaccines, of the ability to neutralize the virus. But again, kind of another important thing to understand is that, you know, there's the kind of the antibody responses and how they are impacted by the virus. And then there's also kind of the clinical efficacy. Not to say that the clinical efficacy of a vaccine would be diminished by the novel viral strains, but we need to understand a little bit more exactly about their impact.
And I think just to add, I mean, that's one issue. These variants that are popping up now remind us that it's really important as much as possible to stop transmission, meaning that all the protective measures that we keep talking about are very critical, because as the virus gets transmitted from one human host to another human host, that's how these mutations, these variants arise. So we want to do two things. We want to be working on scaling up vaccinations as fast as possible, at the same time trying to suppress transmission also as low as possible as we're doing so, because that's one way of decreasing the risk of new variants arising.
And that's why, sort of to echo what you said earlier, you know, wearing face masks, hand washing, social distancing, all of that works.
Great, thank you. And again, I'm going to stay with the theme of COVID-19, and we have a question about our focus has been on testing, our focus has been on the vaccine, but what about curing COVID-19? What can we expect, or what work has been done in that vein?
There's been a lot of work to try to identify treatments for COVID-19, and we're now in a much better situation than we were in several months ago. We do have antiviral drug that's remdesivir, that's an antiviral that's been recommended for treatment. We also have a lot of research ongoing, as well as at Columbia itself and elsewhere, looking at what are called monoclonal antibodies. These are antibodies are produced in the laboratory, are injected, and these have also been shown to be of benefit in some subsets of patients with COVID-19. Not very severe COVID-19, but with less severe COVID-19. So I think research is moving fast in both areas in terms of finding more vaccines, and that keeps on going, but also in finding better treatments for COVID-19.
Great, thank you. We have some questions about allergies and in general allergies, but also specifically penicillin allergies. And what would you advise about getting the vaccine?
Yeah, I can start, and then you can add, Wafaa, because we've talked a lot about this in different forums. I think it's a great question, and sort of depends a little bit on what specific allergic reaction it is. But in general, if it's a history of allergies to not to this specific to this vaccine itself, but to a range of other things like penicillin, it's not a contraindication to receiving the vaccine. What would be required, however, is maybe a slightly higher level of a longer duration of monitoring, depending on what the reaction was. Typically, we monitor individuals up to 15 minutes, and the individuals who monitor post-vaccination, they're well equipped to handle allergic reactions. They're well trained. That's why it would be prudent to receive such a vaccination in a kind of a more clinical setting if someone has an allergic reaction to or severe allergy, maybe to penicillin or other agents. But it's not a contraindication to receiving the vaccine.
Thank you. Another question about potential reactions to the vaccine. This is a question about, I've recently heard of platelet or clotting concerns for people who have low blood platelets, as well as throat swelling days later.
Start, I think there's been one report in the media that I'm aware of one individual who had a drop in their platelets, who was vaccinated, and a couple of weeks later had a drop in the platelets and so on, and had severe complications, and actually that person died afterwards. All the information on this case, as far as I know, has been from the media. I have not seen an investigation of this case in particular. I think it's really important to wait till we have more data on this case. So stay tuned.
Great. Wafaa, thank you. And if you could just speak up, a few people have commented it's hard to hear you. Thank you. And then I'm going to ask our moderator, we have a request that if you could put into the thread here, which is the link to sign up to volunteer. I will tell you that we have closed the volunteering temporarily because we have so many and we're sorting it out, but you should certainly know where that is. And also the COVID-19 website, which is easy, covid19.columbia.edu, so that you should be able to get to that. We also have some questions, and then I'm going to let Wafaa and Magda take a break for a little while. We have some questions about the difference between the Moderna and Pfizer vaccine. If perhaps Magda could take a stab at that one.
Yeah, so difference in terms of the efficacy, right? For example, so, both are, I would say they're essentially equivalent. If you squint, one is 95% efficacious in preventing symptomatic COVID illness, the other one 94.1, but it's essentially remarkably equivalent, which is actually, an amazing feat actually that they've sort of come so incredibly close and comparably, quite comparable to each other. In terms of also the kind of reactogenicity and side effect profiles are also very, very similar. So I would urge people sort of not to worry, and whatever is available to go ahead and get vaccinated with that agent.
Great, thank you. So I gave them all the hard questions. I'm going to answer one of the easier ones. This is a question that came in before the meeting. Let's say 4 friends, all vaccinated, want to meet at one's house for dinner. Can they do it, and can they do it without masks? So my answer is no, you should not do it. And we also have related questions about, does having the vaccine mean that you can't pass it from one person to the other? That's not clear, but it is certainly, as you heard, each of the speakers say, keeping face coverings on, limiting your close contact. And quite frankly, just because you had the vaccine, you might have had 1 dose, maybe you had 2 doses. It could be the day you had 2 doses, and it's not been proven to be effective at that point in time. So don't have dinner yet. Let me turn to some eligibility questions. I'm going to ask Gerry if he could address these. One is, who is an in-person instructor? Is it the faculty member? Is it the TA? And the easier part of this is in-person instruction limited to instructors teaching just in this current spring term? Gerry?
Yeah. So the first point to make about in-person instructor is that these are not our words. We didn't come up with these words. The state came up with them. The governor did. And having imposed them on us, they quite unhelpfully didn't bother to offer any explanation of exactly what they mean, nor did they establish any clear standard by which one is to demonstrate that one is an in-person instructor. So what we have done is to try to look at this and take a literal, plausible interpretation, because our fear is that if we or any other institution is perceived as just over-reading these eligibility criteria and opening the doors to anybody who wants it by stretching the definitions, that we're going to hurt our ability eventually to get our own vaccine, which we'll be able to administer. So the position that we've taken so far, based on the guidance that we have to now, is that an in-person instructor means someone who is actually engaged in the instructional process, not a staff member, even if the staff member is also interacting with students. It needs to be someone who is an instructor. But an instructor doesn't necessarily mean a faculty member narrowly defined. An adjunct faculty member who is going in and interacting with students should qualify. A teaching assistant should qualify. They are instructing, and we believe that they are eligible. The last piece of this, Donna, you said, what was the easy part that I was to address?
Boy, I was too busy listening to you. I think it was,
so maybe we covered it.
Yeah, I think you covered it. I think you did cover it. Good. So thank you. We have some questions that relate to equitability around who has been prioritized for the vaccine, and that many of the CU employees who are in lower ranking, in quotation marks too, lower ranking jobs, not faculty, for example, who are teaching in person, or not clinicians on the CUIMC campus. And what are we doing as a university to lobby, promote the fact that there is right now the appearance, at least, of an inequitable distribution of the vaccine based on race and ethnicity? And maybe I'll turn to Wafaa for this. She is a champion of this.
Well, I mean, I think one of the important things to think about, I always say that we really need to think of equity. Equity in and of itself is very important to achieve, and we know that certain communities have been most severely affected by COVID-19 in terms of acquisition of infection, but also in terms of complications of disease itself. At the same time, we also as well are well aware that from a public health perspective and in terms of controlling the epidemic, we really need to go to these communities because that's where transmission is more likely to happen, and so on and so forth. So the challenge is how to do so, and that's something that Donna and others on this call discuss almost every day. Is how do we get there? And part of it is by, I believe, is that even if you think about the currently eligible populations, whether they be healthcare workers or individuals 65 years or older, is we need to be very cognizant of within those groups who are we reaching, and be looking carefully at the demographic composition of these groups that we're reaching, and think about how to reach the groups we are not reaching. How can that be done? Sometimes it's by addressing issues that I raised regarding hesitancy. These groups may have concerns about the vaccines, and we need to be able to address these. We need to identify champions, like Donna said, as we're doing from the communities themselves. And I really think we also need to make it very easy for them, because sometimes there are access issues, availability of vaccine issues. And I'm a big believer, you have to go to the people, not wait for them to come to you. So we need to be thinking creatively of how to set up vaccination sites within most affected communities, how to reach people who are homebound, for example, who are homebound, and get vaccines to them. So I think we need to be really thinking about how do we monitor what we're doing, and appreciate where we're doing well, where we're not doing well, and then how do we problem solve as well, and take the vaccines to the people who need to be vaccinated. And lastly, I think we also need to ask people, what are their concerns? We need to also ask them, can they access the internet? Can they make an appointment? Can they persevere in making an appointment online? We know that these can be very, very huge impediments for some of our populations. So I'll stop here, Donna.
We've also had some questions about the varying effectiveness or efficacy of Pfizer versus Moderna for people who are multiracial. Is there any more data or information that you could provide on that? Wafaa?
I'll give it to Magda since I just finished speaking. Magda, you want to?
No, thank you. And I think, there are really no data to suggest that there are any differences. Both studies tried really hard to make sure that there are sort of diverse populations are included and represented, just so that we would be able to say, whether sort of it, how well it works and how safe it is in very diverse populations.
I think also I caution people to be careful, because sometimes there are small numbers in specific subsets so I don't know how many people were, for example, multiracial in those studies. So if you have very small numbers, sometimes that in of itself may give you an illusion that this is better than this. So be careful also in looking at the data, and we're certainly here to answer the questions, because sometimes when there are very small numbers within a stratum of individuals like multiracial or other characteristics, you can be misled by the data that you see.
Thank you. Gerry, I'm going to turn to you for a couple of additional questions about this vexing definition of an in-person college instructor. So we have one question: are administrators who present to large groups of students deemed to be in-person college instructors?
So I also remembered what, Donna, was the easy part of the last question. I'll come back to that. So I don't know how to answer the question about the administrator, because I don't know enough about what that person is doing. What we have suggested to the deans is that they provide letters to their own people who are engaged in in-person instruction, so that as you get an appointment and are able to go in, you'll have a piece of evidence to show. I think the administrator question, that person needs to talk to their own officials in their own school about what exactly are they doing. And as a general matter, staff members should not be eligible. But if we have an administrator who is actually involved in instruction, I think that's going to qualify, but it needs more facts than I've got. The easy part of the question before was, did it have to be this term? And the answer is yes. It's the fact that you may be teaching in May doesn't qualify you now. Sadly, the fact that you did teach in person in November doesn't qualify you now. And again, these aren't our choices. This is what the state has said.
Great, thanks, Gerry. A related question is a professor who is asking, even though this individual is teaching online, they would like to gather with their graduate students for conversations about the class. And would that person get priority in some way to get the vaccine as an in-person instructor?
So again, I think needs more details. That I would say take that up with your individual school leadership and talk to them about what you're doing. We have to define the term narrowly, but we understand there are a lot of different cases. And I think that your school leadership that's the place to take that question.
Great, thank you, Gerry. We have a question, and I did make the comment in my slides that even though the governor announced about 10 days ago that in the 1B category were people who are immunocompromised, he didn't define what that meant. And what I also said, though, was that getting through 1A and 1B would take perhaps 4 months or more. Now, that doesn't mean that sometime in the next weeks or month that the governor's office wouldn't come out and define immunocompromised. What I was referring to is, and so as long as they're in the 1B category, they presumably will be eligible, and we will be waiting for those definitions and alert everybody once we find out what that means. Some states have given quite a lot of latitude. And you may be familiar with New Jersey, who didn't even use immunocompromised. They used the other term, underlying medical conditions, and deemed that smoking and obesity were underlying medical conditions. So I think on some level, while I think the state is very empathetic to this group, the sheer number of people that are just in the over age 65 category, as well as the patient facing, is so large that they'll be a lot more frustration around trying to get appointments when you're only getting 300,000 doses a week for 7 million people. So sorry, that's a long answer, but it is a complicated issue, and one that I think we're very empathetic to in terms of the individuals that have those conditions. Similarly, we had a question if diabetes creates some eligibility. It does not, again, not defined as an underlying medical condition, and so we're just in limbo in terms of that. Okay, I am sensitive to the fact that we've got only a few more minutes. I have one quick question, which is somebody who has to travel in a wheelchair. And is the wife of this person or the spouse of this person able to come to the vaccine site even though they're under the age of 65? Absolutely, they're able to go. If you can book into the Armory, there is a first floor accessible entrance that doesn't require any stairs or any ramps or anything. And clearly you can bring somebody to support you. It is safe. You cannot come into any of the vaccine sites without face coverings, and there's plenty of signs that maintain physical distancing. So maybe one quick answer of Wafaa and Magda before we turn it back to Ira, which is the Johnson & Johnson vaccine going to be an option in the near future?
Well, I think we hope so. I think the studies are fully enrolled, and actually Columbia participated in these studies as well, so that's good news. And Magda is co-leading one of them. We're hoping that within the next several weeks to maybe a couple of months that we will have answers in terms of whether these vaccines are effective and safe. So stay tuned.
Well, great. I want to thank all the panelists for their contributions. We did actually answer 51 questions live through responding directly to the individuals. We have a few open questions which we'll incorporate into our frequently asked questions. And let me turn it back to Ira for some closing remarks.
Let me first add my warm thanks to you, Donna, to Wafaa, to Gerry, to Magda, for this illuminating, really helpful conversation. And let me underscore that it's the goal of everyone here to have the institution, Columbia, move as quickly as possible with our quite wonderful partners at NYP to get as many, indeed all the eligible community vaccinated as quickly, as efficiently, as effectively as possible. The constraints we face are those of regulation and supply, and we're very keenly hoping that we can move ahead thoughtfully and expeditiously, just as quickly as the regulatory environment and supply permit. And as both Gerry and Donna have said, we keenly hope that sooner than later, the university itself, Columbia doctors and the university, will have our own supply that will complement that at NYP. But until that happens, we will continue to work very closely with NYP, as we will long into the future, to expedite safe inoculation, effective inoculation, and expeditious inoculation. And I thank everyone and wish you all the wish to stay safe, and if necessary, be patient. We will all get there. Thank you so much. Take care.
Bye-bye.
Thank you.
Bye-bye.